get involved at the pubertal stage so that kids are able to pass in society as transgender, as the gender of their choice. So pubertal development in itself is an experience of the first somatic signs of hormonal puberty, which is alienating and diagnostically significant as a marker that gender dysphoria will likely persist. So it is the beginning of breast buds in a girl who feels like she should be male that is quite disconcerting. And obviously the opposite is true for boys in terms of growth of their genitalia. So in girls, this happens sometime at around 10 years of age on average, with their menstrual cycles starting at about 12 and a half. And in boys, it starts with testicular enlargement at 11, which may or may not be that noticeable. But certainly by the time they're 14, 15, the other effects of testosterone are taking place and are noticeable. Criteria for puberty suppression by the WPATH guidelines. Same idea, long-lasting, intense pattern of nonconformity and dysphoria. It worsened with the onset of puberty, which is often when we see them. There are coexisting psychological, medical, or social problems that are already being addressed or treated. And the adolescent gives informed consent. The parents have consented and are supportive. This is how we treat kids in early puberty in terms of puberty blockers. So GnRH, if you'll remember back from medical school or residency, it's the hormone that gets secreted by the pituitary gland down to the testes or the ovaries and tells them to turn on and start secreting sex hormones. That's what puts us into puberty. Quite paradoxically, if it is not seen in the body as a pulsatile hormone, but we inject it once a month as a stable, slow-release hormone, the body doesn't understand what that means. It gets confused and it shuts down. So it effectively shuts off all of puberty from a central place. It's not really considered medication. It has no side effects. It's bioidentical to the hormone your body would see anyway, but it's just given in a different format. We started to look at some long-term effects. So this is an earlier study in 2011 by DeVries, and this is her, I think, follow-up study. They've lost some kids, but this looked up to them out to 20 years. So this one just looked 12 to 16 years at Tanner stage, 0 and 1, or none and some. And they looked at some validated questionnaires and found that if you block them, they have better behaviors and less depression, but it really doesn't do much in terms of body satisfaction and gender dysphoria, which makes sense. Their body still looks different than they want it to look. I've just stopped it where it ended up developing. When we looked at them at 13 when we stopped their puberty, 16 when we started cross-hormone therapy, and 20 when they had sex reassignment surgery, in general, people who go through the entire gamut of transition have improved global functioning, have well-being similar to peers, and they actually started to look at educational attainment and vocation, and they were very much the same as the underlying Dutch population, which is pretty good, actually. We're doing well. Criteria for partially reversible interventions, persistent, well-documented dysphoria. So partially reversible would be considered your Lupron, and then your cross hormones. Capacity to make fully informed decision and treatment for consent, age of majority, and of course we've dealt with your other comorbidities. So hormone therapy is the next step they come to see me for, and it's to induce the sex characteristics that they wish for. Male to female, obviously, to take down the virilization, to cause breast formation, to change their body habitus, and to reduce male pattern hair growth. Male to female hormone therapy, we tend to give them estrogen. It causes them hypercoagulability, all the same risks as you remember when you put girls on the birth control pill, for the most part. Thromboembolism, some liver dysfunction, other cerebrovascular disease could make migraine headaches worse. So the same sort of side effects, and we go through a 3-page consent form for this. Female to male, we want to induce virilization. They want beards and mustaches. They want male pattern hair growth. They do not want the male pattern baldness, which is also a risk when we put them on testosterone, so that takes another page of consent. Male physical contours and cessation of uterine bleeding. So female to male hormone therapy, we obviously use testosterone. I tell female to male youth that I start cross-hormone therapy on, it's really taking your risk as a woman and making it a man's. So it's not that we're increasing your risk, it's just that men get more diabetes, heart attacks, strokes, high blood pressure as a general global population. And now I've taken you from what would otherwise be a woman's risk, and I've bumped you into the category of a man's risk. And that's what you get when you become a man. So that's the risk benefit. That's exactly how I say it. Non-surgical procedures, they can do electrolysis, so hair removal if they want. Vocal cord manipulation, there's a surgical option to have vocal cord manipulation, but most youth will go through speech training for themselves, and that you can do on YouTube, should you wish. Age limits on surgery, right now you have to be 18 or older, so we actually don't send a lot of youth to surgery. We've had one go to have surgery done. When they looked at gender reassignment surgery, for an N of 41, 20 had that at an age of 16.6 years, which is crazy. I don't know, this is somewhere in the UK. And of those who do not have it, the majority met the criteria still 4.3 years later. And this is Zucker's clinic in Toronto, and he just simply reported the amount of kids that wanted to have gender reassignment surgery, which is about half of his patients. Surgical interventions, these won't be new to you. Male to female, they want breasts. Sometimes they want to get rid of the Adam's apple if they can. Rhinoplasty, facelift, penectomy, vaginoplasty, clitoroplasty. So other genital reconstructive surgery. Female to male, they want breast removal. This is where we actually are more active in terms of advocacy for services, as well as writing letters. So we have sent youth at about 16 or 17 to have this done. Not, in fact, the hysterectomy, a nephrectomy, and so on. So just a quick review of what our clinic looks like. Nicole Kirok is our endocrine nurse clinician. She talks to all of the families when they first phone us, or the individuals, because we take self-referrals, and she goes through a bit of a questionnaire so that we get to know a bit more about these kids. They come to see us and or psychiatry or psychology, depending on whether or not it's a pubertal issue that's imminent, or if the child is 8 and has no signs of puberty, then they'll go through our mental health colleagues first. This is our clinic. So I've compared it to the Children's Hospital Boston Clinic. So Norman Spack is quite famous for his work with transgender youth. And then the BC Children's Hospital, because they've been around for 20 years or so. And then this is our clinic from its inception, basically, to date. And this is just in the last couple of years. And the reason I did that was because in the last couple of years, the media frenzy has happened, and I just wanted to see if our kids were getting younger when they come to see us, and whether or not there are other sort of behavioral differences in the group. Generally, you get, this is natal, sorry. Generally, you get female to male transgender adolescents more commonly than male to female. Ages at presentation are around the same time, so this is the onset of puberty that they recognize. Psychiatric history is somewhere between 30 and 40% in all clinics. And the BC Children's Hospital actually talked about admissions to their psychiatric facility, so it was 12% of their patients. Self-mutilation was in Norman Spack's clinic, and then in our clinic in terms of history of cutting behaviors for the most part, which is upwards of 60% for the kids that we see, a little bit lower at the Children's Hospital of Boston. This is suicide attempts in BC Children's Hospital. That's how they gave their data. Child and Family Services involvement, obviously it isn't in Children's Hospital of Boston or BC, but I thought it was interesting to look at the kids that were involved in Child and Family Services. It has its own unique problems with that in terms of treatment and consent, so it's about 15 to 20% of our kids. And First Nations also is about 17% of our population is First Nations, and most of them from remote communities. Resources that you should know about. So this is the World Professional Association for Transgender Health that we were talking about. It's a 160-page document, but there's a synopsis of the treatment options. and guidelines. The Canadian Professional Association is really just a shorter version of this that we cut out for our own. Gender Creative Kids is a great website to look at when you're looking at younger kids in terms of gender fluidity and experience, and helping parents sort of cope with the kid that wants to wear the dress to school when they're a natal boy. Other resources, Rainbow Resource, they've been fantastic. Clinic with a K is the adult version of what we do, in cahoots with Rainbow Resource, who have helped us a lot form our own group. Health Canada, I think we brought some booklets. Health Canada has put out school information. This is for our youth, so there's Advocates for Youth that amplify your voice, which has good stories for youth and allows them to work through questions of gender in a book form as opposed to through Tumblr or on the internet, which is where most of our kids get their information. Ryland's story we talked about a little earlier. Barbara Walters did a great 2020 called My Secret Self back in 2007, and Trans the movie we screened here at the Gas Station Theatre a couple of years ago with the makers of the movie and with our transgendered youth, which was well applauded. And then that's it. That's us and our contact information.